Okay, good morning or good afternoon, wherever you folks are. I want to first of all thank you to AAP for putting this together. It's a really special thing. I know it's taken a lot of work, and we really need to thank the Academy for doing this. So today the session is talk about immediate tooth replacement in the aesthetic zone. I know most of you are probably graduate students or some periodontists are in the audience there. So the question first of all is how many of you really do immediate tooth replacement? And if you think about it, I mean, such as our patient here, whom I saw in 1999, and historically, when do people first start doing immediate implant placement? The article first published about immediate implant placement is probably around 1989, somewhere around there. And then the benefit of that at that time is to shorten the treatment time. You do not need to extract the tooth and wait for the graft to heal before you put the implant in, such as a delay method. And on that 1989 article, they also described that by doing an implant immediately, you actually can preserve the bony architecture. That is something very debatable, all right? And then fast forward a little bit, probably around 1996, 1997 or so, people first start pushing the envelope one step further. They say, not only maybe we can put an implant immediately into a socket, why don't we put a provisional on top of that implant on the day of the surgery? In short, people call this type of procedure immediate tooth replacement. So you're replacing the tooth right away. What is the benefit? At that time, that article in 1998, that's the first article that they published, talk about aesthetic immediate tooth replacement. And they say the benefit is not only you shorten treatment time, you maintain the bony architecture, you also are able to maintain the gingival architecture by putting provisional in there. So at that point of time, everybody got really excited about this type of procedure. And because of aesthetics, right? And a lot of people are doing it. And then fast forward a few years later, 2001 and 2002, I believe that year the Euro-Perio meeting was in Barcelona. And I remember distinctly several really big name periodontists stood on the podium and said, if you do immediate, you better stop. Why? Because not only you're not going to have a lot of failures, you will have a lot of soft tissue problems. So people got a little bit scared. Then a couple of publications in 2002 and 2003, and both of them are dog studies. The last author is Professor Jan Lindy. And if you read those articles and you remember what they did was they extracted the teeth from the poor beagle dogs and then put the implants into the socket right away. And then after that, let the dog play around for a few months and sacrifice the dog. They look at it histologically, what really put a nail on immediate implant placement on those articles is, if you do immediate on the dog, a few months later, histologically, the buccal bone or the facial bone is gone. And you guys remember that bundle bone histology that people often talk about. So since then, there have been so much controversy whether we should do this type of procedure or not. I remember at European Academy of Osseointegration, or even in many meetings, people were debated about this topic hotly. So now 25, 26 years later, is this a viable procedure? What do you think? And let me tell you, over the years, I noticed that a lot of harsh critics on this type of procedure recently also changed, that they say maybe it's okay to do this type of procedure. So going back to 1999, one of my earlier cases that I've done, on our patient here, you can see what I did was I went in, I placed the implant in, and then let's take a look at the healing. You can see throughout time with the provisional at 2 weeks, 8 months, then with the definitive restoration, and at 2006 picture on the right-hand side, you can see distinctly significant marked facial ginger recession. And if you look at the interproximal papillae, they look actually pretty good. So what is the thing that we learn over the years? Over the years, we've learned that when we do immediate tooth replacement, typically it's beneficial for the papillae. Why? Because once you extract the tooth, you put a provisional in there, and the benefit of that is you support those papillae there. And however, if there's any weaknesses, is that facial tissue. All right. Now, doesn't mean that every case you place immediate implant placement and provisionization, there's always soft tissue problem, but the propensity is there. Because of that, over the years, clinicians try to use different methodologies to minimize this type of recession problems. So with that in mind, anytime when we place implant in the aesthetic zones, these are some of the problems that we face, regardless whether we do immediate or delay or whatever procedures you do. So what are some of the problems from an aesthetic standpoint? Well, you may get recession, you may get some discoloration, and also if you look at the tooth from an incisal point of view, and you look at the facial gingival or bony contour, you can see this patient, the facial contour collapse. So mind you, anytime when we deal with aesthetics, those are 3 of the main factors that we constantly as a clinician struggle against: recession, discoloration, and facial contour changes. And mind you, these 3 factors have a tendency to go hand in hand with each other. In other words, if we have a recession, there's a good chance that there will be incisal facial contour changes too. So again, in 2022 today, what should we do? Should we even proceed with immediate tooth replacement, or that should not even be an option for us, right? And with that in mind, I'm going to introduce to you 4 of my patients that I've treated over the years. And again, since the biggest problem with immediate tooth replacement is actually really the facial tissue, most of the time we seldom see papillae problems. That means a significant retraction of the papillae because of the presence of the provisions. And what is so unique is when you look at this 4 patients, you see the arrow that's pointing to you, the tooth that's failing. And then, you can look at the CBCT scan. What you see is this. I intentionally highlighted the buccal and the palatal bone. Now, mind you, CBCT scan is not the best and the only way to evaluate facial bone. Why? Because when a lot of times you notice that despite the fact on CBCT scan, you may not, even if you don't see the presence of buccal bone, a lot of times actually is there. But at least it gives us an idea. So what you see is this: patients, the first 2 patients on your left, the buccal bone is intact. The 3rd patient from the left, the buccal bone is actually compromised. And then if you look at the patient's far right on the far right, the buccal bone is basically not there, very obviously. So what type of cases is good or beneficial for immediate? What type should we stay away? And what I'm going to do is the next hour and a half or so, I'm going to give you the idea about what are the current concepts and what works and what doesn't work. Now, mind you, the purpose of this presentation is not to impress you with some cases that a clinician did or I did here that it looks good and then, whoa, you should go and do it. The point is, what type of science do we have underneath there? And I understand that there's a lot of graduate students in there, so you may want to take a look at some of those literatures too, all right? So let's take a look at our first patient here, failing right central incisors. And you can imagine patients like that with very high, the phenotype is basically on the thin scallop type, all right? And those are typically more challenging based on the literature Why? Because thin gingivals have a high tendency of recession and so forth. But we'll talk about those kind of things. How should we manage this patient? Now, I'm going to list out 6 items on this little list on the left-hand side for you to consider. Those are the things in my practice I always evaluate whenever a patient comes to my office with a front tooth that's failing, right? The first thing I look for is gingival thickness. Now, you can look at this patient, you can see the tooth failing because of root resorption. The first thing we typically look at is gingival thickness. How do we evaluate gingival thickness? For me, it's very simple. I like to, before I anesthetize the patient, I like to take a periodontal probe and probe the mid-facial aspect of that tooth that I'm working on. And after I probe it, I gently lift that probe towards me facially, just gently. And what I'm seeking for is, do I see the vein outline of the probe shining through? If I see that, I will consider phenotype on this patient on the thinner side, right? So what is so significant for thin gingival phenotype? Well, again, some literature, such as that 2011 article from International Journal of Oral Maxillofacial Implants, tell us that when we place implant in the thin phenotype, it increased the risk of facial gingival recession compared to thick phenotype. Now, what is the best method for you as a clinician to evaluate gingival thickness? Now, I mentioned to you that early on, my favorite method is the probe. But let's take a look at what this article did for you. What the authors did is they look at what they call biotype at that time. Okay, now the right term is phenotype. Okay, please remember that. The facial gingival phenotype in the aesthetic. So visual assessment versus direct measurement. In other words, there's a group of patients on this study that require a front maxillary anterior tooth that need extraction and implant. Prior to the extraction, the authors used 3 different methods to evaluate gingival thickness to see which one is the best method, all right? So the first method is visual. That means you look at the gingiva to see whether it's thick or thin. Then you use the probing method that I described to you previously. Then right upon extraction of the failing tooth, the authors take a tension-free caliper to measure the facial gingival thickness, roughly 2 millimeters apical to the free gingival margin, all right? And then they compare the 3. Now, before I show you the data on these publications, let's talk a little bit about what do you know about the average facial gingival thickness of maxillary anterior teeth. I did a summary on, majority of the publications and mostly the periodontal journals on what is the average facial gingival thickness. And most of those studies are like root coverage studies. Prior to the root coverage, they measure gingival thickness to see, does the thickness of gingiva play a role in, how successful you can get the complete root coverage with root coverage procedures. And based on that, the average thickness of the gingiva is somewhere between 0.7 to 1.5. That's the rough numbers that you get. Of course, there's a few articles that show a little greater, tissue thickness, but the general range is 0.7 to 1.5. So in other words, the average gingival thickness of maxillary anterior teeth is actually not very thick, right? Not very thick. So how do we further define thick or thin from a numerical standpoint? Well, again, the literature, such as this publication here, also suggested that, well, why don't we draw a line and cut those numbers right in the middle, 0.7 to 1.5, and you get roughly 1.1. So in other words, from a numerical standpoint, anything less than 1.1 millimeters, we consider the gingiva to be on the thinner side, whereas when it's greater than 1.1, it's a little bit on the thicker side, all right? So let's go back to these articles. When they compare the 3 groups, first of all, they look at 48 maxillary anterior teeth, and using the direct measurements, that means right after extracting tooth, use a tension-free caliper to measure the gingival thickness. The mean facial tissue thickness is 1.1 millimeters. So it's right dead on with what the literatures talk about. Then on top of that, the range is between 0.6 to 1.5. Again, that's really close to what the literature have been showing, all right? So what do they get when they compare the three methods? Which is the best method now? Obviously, the best method is actually the control will be the direct measurement, right? Because you do direct measurement, that's the best method. The other two methods more subjective, visual and probing. So how do they compare based on this study? This is what they find out, all right? So V stands for visual, P stands for probing, and then M stands for direct measurements, all right? So if you look at the symbol between the numbers that they're not equal to each other, all right, not related to each other. And if you look at those percentage, so this is what we learned, all right, from this publication. If you believe in doing visualization to dictate the patient's gingival phenotype, this article tells us that is not reliable at all, right? Now, probing is actually as effective, almost as effective as direct measurements. So in a sense, as a clinician, at least from my standpoint, I like to use a probe because it's not very easy to do direct measurements all the time. And that probe will be the most indispensable instrument. You just probe it and see whether you can see the probe, and that will tell you where the signal is in. Now, however, in my practice, I basically look at, I treat most patients' phenotype regardless sickle thin is on the thinner side, all right? And now, how do you manage it? Well, as a clinician, one of the ways is if ginger is on the thinner side, we tend to do a little bit more what you call minimally invasive procedures, such as try to be a little bit more flapless approach, maybe a little bit more perioplastic approach, and in also to a great degree, we consider about doing tissue graft, connective tissue graft to try to thicken up the phenotype, all right? And those are things that we'll talk about in a little bit. So anyways, to conclude here, the best way to evaluate gingival thickness is actually use the probe, all right? At the least invasive way too. Now, let's talk about the bone. People often talk about the bone sets the tone of the gingiva. Some of you heard about that. And to be honest, on the facial aspect of the tooth, this statement, the bone sets the tone, is not always true anymore, all right? And I'll explain to you why in a bit. Because we know that underneath the facial aspect of the tooth, if you reflect the gingiva, you will always bound to see a piece of bone. The question is, how far is the bone underneath the gingiva, and what impact would have to do with the gingiva when we do implant placement, especially immediate? Well, to understand that, I'm going to take you back more than 50, 60 years ago to this classical publications from the Journal of Periodontology, published by three persons, Gargiulo, Wentz, and Orban. Orban knife, so there you go, all right? So this is a cadaver study. What they did is on dead human beings, they took out the jaw of the dead human beings and did histology around the tooth, all right? So you can see that little white box there I highlighted, so we magnified it, and basically that's just a couple things I want you to remember on this histological thing. They find out that the authors find out that histologically between the sulcus to the underlying bone on the facial aspect of the tooth, it comprises three histological components that you all are well versed: the sulcus, junctional epithelium, and connective tissue attachments. And in fact, what we find out that each one, if a patient has no periodontal disease and the tooth has been erupted normally, each one of those histological components has an average dimension. Of course, it's a range too, but the average dimension is around 1 millimeter. Therefore, if the patient has no periodontal disease and the tooth has been erupted normally, under most circumstances, based on the literature, more than 80%, 82% of the time, the distance between the facial gingiva to the underlying bone is 1 + 1 + 1 equals to 3 millimeters. That's a normal dimension, all right? And in fact, most clinicians, how do you know whether that dimension is true? When we do periodontal surgeries, such as crown lengthening or gingivectomy, or sometimes implants too, we like to do what you call bone sounding. That means you anesthetize the patient first, and you take the probe and you push it again, lean it against the tooth, of course, first, and then push until the probe doesn't advance anymore, and And hopefully that's what the bone that is preventing the probe from advancing, and you get a number, and that number is the bone sounding number, all right? So that is the kind of like the non-invasive way to measure that so-called the dental gingival complex dimension. Now, of course, we also need to be aware that what we call now the supercrestal fibers, all right? Previously, people called the biologic width. Supercrestal fibers, actually biologic width is a term coined by people like Walter D. Cohen, and some people give the credit to Kramer, all right? But regardless, what comprises the supercrestal fibers is the junctional epithelium and the connective tissue attachments. And so the average dimension is around 2 millimeters, all right? So those are the things that you need to know about. So the average dimension, whenever we look at a tooth facially without periodontal disease, 82% of the time is around 3 millimeters. Now, bone sounding does not mean that it's always 100% accurate, okay? Why not? If you look at this article published in 2017, what the authors did here, and Kim is actually currently one of the graduate perio directors, okay? And what the authors look at is the accuracy of bone sounding. How accurate is it when you do bone sounding as a clinician? So the design of the study is actually very simple. A front tooth that's failing, before extraction, did bone sounding, of course, anesthetize the patient first, and then you get a number. Then, after extracting the tooth, without the presence of any type of obstacles, such as calculus or morphology of the root and or attachments, you should be able, the clinicians are able to measure the tissue to the underlying bone in a much more accurate manner. And by doing so, what the authors look at is, for example, this patient, we did bone sounding and it's 3 millimeters, but actually there's a huge defect. The facial bone is not there. All right. So based on this article, they look at 190 failing maxillary anterior teeth when they did bone sounding before and after extraction. What they find out is the accuracy of bone sounding based on this patient population, okay, is around 83%. So in other words, ladies and gentlemen, there's a group of patients that when you do bone sounding, you may not always get that perfect, estimation, all right? Now, underestimation is like 14%, overestimation is 26%, all right? So those are the things that you need to keep that in mind, all right? Now, how do we make the diagnosis? Well, for me, anytime like this patient here, our patient with a failing front tooth, I always do it, takes a few different type of radiographs to plan the case, not only to plan the case, but to select what size implant I'm going to use. So standardly, I always take a periapical radiograph, such as you can see the radiograph on the left-hand side. And what I look for is for those maxillary anterior teeth, where the root apex is and how much bone is there apical to the root there, all right? The general rule based on the literature is you would like, if you plan immediate implant placement, you would like to at least have 4 to 5 millimeters of bone apical to the root tip socket, all right? Those are for maxillary anterior teeth. And the root pretty much holds for teeth anywhere when you do immediate too. Now, when you look at the scan, the axial view on the left-hand side, and what this group of authors here is, with Dr. Zucchelli and others, the authors describe the importance of this to-be-published article, the importance of axial view on the failing tooth. Why? Because we want to know, is the tooth more prominent in the arch, such as in this patient here? And the authors in these publications give the clinician some different type of recommendations based on how pronounced the tooth, how you're going to manage the socket when you do immediate tooth replacement. But the general rule is this: if the tooth is more pronounced, such as this patient here, you see the red line there, that is basically the demarcation telling you that there's a good tendency for the facial bone to collapse into that area there. All right, so the more pronounced the tooth, the more challenging from an aesthetic management standpoint, such as this patient here. Then when you look at the scan, the picture, the sagittal picture on the right-hand side, the CPC scan, I want to use this to look at how do we plan for, immediate tooth replacement. Now, one of the articles that was published several years back, the authors mentioned what you call sagittal root position. That means how does the root position itself in the premaxillary bone rehousing. And in this situation here, you can see the root is tilting facially, which is what they call the sagittal class 1 position, all right? And how do you plan for what size implant do you use? This is what I do, all right? And now, let me tell you, it doesn't mean that I know everything, but this is what I do in my practice, all right? First of all, I will locate where the facial bone, the ideal facial bone is, all right? And then the palatal bone, and I draw a line across it, measuring the buccolingual dimension of the socket here, all right? And then after that, and then you can see in this particular patient is around 6.7 millimeters. And so what does that mean? I'm trying to look at what diameter implant should I use. Now, if the buccolingual dimension is 6.75 millimeters, and when we do immediate implant placement, we know now the general rule is we want to leave roughly 1.5 to 2 millimeters of distance between the implant and the buccal bone. Now, this has not been mentioned in the literature yet, but it will be. We also would actually should leave at least 1 millimeter of distance between the buccal, the implant, and the palatal bone for prosthetic emergence profile. And because of that, if you look at 6.75 minus 3, you get 3.75. So does that mean we can select an implant that's 3.75? The answer is no, because I always like to leave a little, margin of error. That means, I always ask myself, what is the next size implant down that I can use? And in this situation, the plan is to use an implant that's 3.5 millimeters. So give that margin of error. Lengthwise, this is a rule there, because when we do immediate implant placement, there's the tooth, and the tooth, the socket is basically air, kind of like, Michael Jordan, air, right? The rest of it is, you got to, in order to achieve success, you must engage the implant into the recipient bone. How much recipient bone? Well, this is what, some of the latest literature to be published material will show. If the clinician engage the implant in less than 30% of the implant engaged into the native bone, and you put a provisional in there, you actually increase the risk of implant failure. So the general rule is, you want an implant that is long and big enough to be able to engage more than 30% of the recipient bone, all right? So going back, how do you position the implant? There are a few things that I want to go through with you guys. How deep should you place the implant? Well, the general rule is wherever you, use the so-called predetermined margin of the definitive crown. In other words, wherever you want the crown to come up from the gingiva facially, that will be your reference point. And from that point on, you should put, as a surgeon, you should put the implant between 3 to 4 millimeters, apical to that reference line. All right. Now, can we put an implant 5 or 6 millimeters? You can. Would that always create a problem? Not necessarily. But the problem is like that. When you put an implant very deep, it's almost like when clinician, the resulting tends to prep the crown, and they put the margin of the crown very much subgingivally. And then you start encroaching upon the so-called supracranial fibers. Now, the problem is people say, oh, well, maybe that will create biologic width violation and problems, but not necessarily. The biggest problem when you prep the margin too deep into the gingiva, you actually increase the risk of, making it very difficult to make impressions and so forth. So same thing for an implant. You put an implant too deep, down the road, let's say the implant having periimplantitis, and then you are getting yourself into a really difficult situation there. That means whatever you do, you're bound to have significant aesthetic problems. And how about the buccolingual position? Well, what I like to do is this. I look at a corresponding tooth, and I draw a line bisecting the tooth buccolingually. So that means the buccal half, 50%, palatal part, 50%, right in the middle. The middle of the implant should be roughly 1 to 2 millimeters palatal to that line. Now, not only that, if I draw a line connecting the facial aspect of the adjacent tooth, the facial aspect of the implant should be minimally 1 millimeters behind palatal to that line too. Okay, that's called the safety zone here for aesthetics. Now, how about sagittally? How should we angle the implant sagittally? In my opinion, especially nowadays with all those angle channel abutment that the restorative dentists can use, which I'm going to describe in a little bit for you. The best implant position is probably aiming at the incisal edge, all right? I seldom aim my implant into the cingulum anymore because of that restorative option now. So just to summarize, for immediate implant placement, the key is immediate stability. If the implant is not stable, you will not be able to get success. So how do you get stability? Number one is you got to have 4 to 5 millimeter bone able to root tip, and you want to engage the implant towards the palatal bone, something like that, and at least a good 30%. Now, unfortunately, not every patient said you can engage the bone palatal to the socket. Why? This publication published in 2011 tried to address that. What they look at is a group of patients, 200 patients, maxillary anterior tip, canine to canine. And then they do a sagittal cut. Therefore, you have 1,200 sagittal cuts. And what they look for is how does the root interact itself sagittally into the premaxillary bone rehousing. By doing so, they were able to basically, find out that there are 4 groups, 4 classes. Class 1, as you can see, the root is tilting buccally, literally touching the buccal bone. Class 2, the root is situated right in the middle of the bony housing. Class 3, the root is tilting palatally, literally touching the palatal bone. Now, you have also class 4, in which the buccolingual dimension of the root is actually greater than the buccolingual dimension of the premaxillary bony housing. So if you look at those are the 4 main groups of roots positioned in the premaxillary bony housing. So if you were to do immediate implant placement, which one do you think is the best group then? Well, to be honest, if your practice is referral based, most of the restorative dentists actually prefer you to place the implant in a class 3 situation. Why? Because they all want a screw retain position, right? Prosthetics. However, as a clinician, as a surgeon, most of the time when you do immediate implant placement, you usually end up placing it in the class 1 situation, in which renders it almost like a cement retain. Now, why is that? Because when we look at the data from this publication, the frequency of distribution between class 1 to 4, interestingly enough, majority of them are belong to class 1, 81%, whereas class 1 only, class 3 only, have 1%. So there you have it. In other words, when we do immediate implant placement in the SX zone, it is not easy to consistently put an implant in a screw retain position. And therefore, you usually end up placing it, aiming it at the incisal edge, and render it into a cement retain. Now, this article just recently published in 2021 at the Journal of Maxillofacial Implants. And what the authors did is something just to confirm the challenges clinician surgeons has in attempting to put implants immediately in a screw retain position. So they look at, again, using CBCT scan, and they use a computer-guided software planning to position implant into the sagittal maxillary anterior teeth. And the goal is to put an implant so that you can put it in the screw retain position. How many of them? If you look at the situation on the left-hand side there, you can see that implant can be placed in the screw retain position, no problems, right? And the patients on the right-hand side, you cannot put it in the screw retain position unless you perforate the bone. So the rule on this study is you cannot perforate the bone. In fact, you need to leave at least 1 millimeter of distance surrounding the implant of bone. Not only that, the implant need to be engaged over 30% of the native bone. So by doing so, let's see what the data show you. So again, they look at 1,200 sagittal cuts. None of them have periodontal disease, no pathology or any type of GTR procedures, and using computer-guided software to plan an implant. And let's see the data. This is what they find out. All right. Look at the column highlighted in red there. You looking at maxillary central, laterals, and canine, and with different diameter of implants. You notice that the chance of being able to use a guided planning to put an implant consistently in a screw retain position is very low, between 10 to 40%. Not very high at all. Now, so what happened nowadays? Remember earlier on, we talked about this thing called angle channel abutment. And in my opinion, for the restorative dentist, that's kind of like a life-saving device. Why? Because a lot of times, if you look at the CBC scan on the right-hand side there, in which the surgeon, there's no way in this case here, the surgeon can put implant in retained position, screw retained position. What happens if the restorative company, can provide the restorative dentist a channel, a crown in which you can change the angulation of the implant position into a screw retained position. And most of this system, most companies have this type of system, and most of them can change angle up to around 25, sometimes to 30 degree. Okay, so range from 20 to 30 degree changes. So what happens? The question is on the patient on the right-hand side, if the implants cannot be placed in a screw retained position, utilizing this type of angle channel abutment, how often can you change them into a screw retained position? So going back to this study here, for this group of patient in which there's only 10 to 14% of the cases in which you can use screw retained position, implant position. If by using the ASC angle channel abutment, how many of those non-screw retained implant positions can they be restored in a screw retained position? All right, that leads to part 2 of this to be published, to publish publications here. All right, and then they look at using the ASC, how often can you change the angle to make the implant screw retained? So this is what the authors find out. So look at again the column highlighted in red. You can see now majority of them, over 75% of them now you can make it into screw retained. All right, so this is kind of like a big winner for the surgical community. All right, so despite the fact that you place an implant in a non-screw retained position, the restorative dentist can use this ASC to change the angle. All right, in my opinion, the key to make it work is minimally for you surgeons out there, when you put an implant in a non-screw retained position, at least aim it at the incisal edge. By doing so, most of the time, the restorative dentist can utilize this ASC as a screw retained. All right. So when we look at immediate tooth replacement, how should you position an implant? To be honest, this is the ideal position. So this is the root apex. This is ideal implant position in extraction socket. In other words, let me back up to make sure you understand. You can see the root apex is right there. All right. As a periodontist, when you do immediate implant placement, you should seldom aim at the root apex. If we aim at root apex, majority of the time your implant will be blowing through the facial plane. Why? Because remember that article we talked about, the saturated root position, 80% of those roots are in a class 1 tilting facially. So therefore, you actually want to aim the implant parallel to the root tip socket, something like that. That's the ideal situation, all right? In the ideal socket, that means your implant is smaller than the socket, and then you should see a gap between the facial as well as the implant and the facial bone, all right? That will be the ideal incisal position when you look at an immediately placed implant. Now, when we see the gap, should we graft the gap? How should we manage it? Nowadays, we know that we should always graft the gap, all right, on the literature. I don't think any clinician out there tell you that you should not graft the gap anymore. And what type of graft do I use? I usually use xenograft that works better than autologous marrow or allograft. We did a study that comparing, when we do immediate implant placement, placing xenograft in the gap versus allograft. And what we notice is with the xenograft, we actually can maintain the facial contour slightly better than using allograft. All right. So typically what I like to do is using small particle xenograft into the socket there. So going back to our patient, right, you can see high smile line, difficult case scenario. How do we manage it? Well, let me back up. The goal for immediate implant placement is not just to get an implant being stable. The goal is to get the gingiva or maintain the gingival architecture. Now, when we look at the facial aspect of the gingiva with the underlying bone, how should we maintain it? Well, in my opinion, there are 2 things that we need to try to maintain on an extraction socket. First, we call that the hard tissue zone. Okay, that means, remember, the bone typically is approximately 3 millimeters underneath the facial gingiva. So from that area on the crest of the bone all the way to the apex. We call that the hard tissue zone. How can we maintain the hard tissue zone? Well, clinicians have various methods, all right? We know that we always should graft the gap. That's given. That's fact right now, all right? Some patients, especially when teeth are more prominent in the arch like this one here, some clinicians will consider about what they call grafting outside. Now, in general, it's almost like contour grafting. Contour grafting, how do you do contour grafting? With what? We can either use bone graft, contour bone graft, as denoted by my dear friend Daniel Buser, all right? Or we can do what you call a contour connective tissue graft, in which we can't term that with using a gingival graft that span all the way from the facial gingival all the way to the hard tissue zone. We call that contour connective tissue graft. Now, another way clinicians can consider is to do root shield. Somewhat controversial, but we'll briefly talk about that, all right? So that, in my opinion, those are the two main methods when we do immediate implant placement that we can control the facial contour, the hard tissue zone. You always graft the gap. You either graft outside with either tissue graft or bone graft, or combine contour connective tissue graft or bone graft, or you may leave a piece of root, a fragment of the root to maintain the facial gingiva, all right? Now, then there's the soft tissue zone. What is a soft tissue zone? Soft tissue zone is between the facial gingival margin all the way to the bony crest, right? That's the soft tissue zone. Because there's no bone there, that's the soft tissue. How do you maintain it? Well, based on the literature, there are two ways to maintain this facial soft tissue zone, all right? We either use a scarf connective tissue graft, which again, I'll talk about all these things, or maybe as my dear friends Steve Chu and Dennis Tarnow talk about the dual zone grafting technique, all right? So how does it execute? So going back to my patient here, our first patient. So you can see I extracted a tooth, and you can see the root tip on the left screen there, and you can see my initial osteotomy. Again, I cannot emphasize enough is to make the osteotomy more palatal to the socket there. Then I place the implant, just like what I described, leave at least 1.5 minimally facial and 1 palatally, and graft the gap with xenograft small particle, all right? All right, so how did I execute this situation here? So first of all, if you look at the pericarpal radiograph on the left-hand side, we want to make sure we engage enough implant apical to root tip socket, 4 to 5 millimeters. And then what I did is, you can see that I did a little slit incision there, all right, on the second picture from the left there. And, people can call it whatever. I mean, basically, put aside all the terminology, it's just a very simple slit incision in the vestibule. So to tunnel some bone graft in there, all right? And then you can see on the picture, third picture on the left, I have a tiny piece of sashimi right at the crest there, just AKA connective tissue graft. So how does it work? Basically, this is the same patient right after immediate implant placement. And I always graft the gap with xenograft small particle. And because of this patient here, the tooth is really pronounced on the ridge. What I decide to do is to graft outside. And then in this situation here, I do what you call contour bone grafting, all right? Through that slit incision and the vestibule, so I just tunnel it, full thickness dissection, and then I pack the bone graft into that. Now, what graft I use? Again, small particle xenograft, all right? So it's just the contour grafting. Now, how about the tissue graft? How do I do that? Well, first of all, let's talk about provisional. Because we're doing immediate tooth replacement, the provisional, the restorative dentist must under contour the facial aspect of the provisional, all right? So to allow the reception of the scarf connective tissue graft. Why do we call it scarf? Because it's like a scarf around the neck, right? So this scarf is right at the soft tissue zone, spanning from proximal to proximal. Usually I seldom put it circumferentially around the entrance. I just put it from interproximal to facial to interproximal, something like that, all right? So in fact, this article should be published in 2023. What the authors, with my dear friend and actually former graduate student, Istvan Urban, and also my dear friend from Bologna, Kelly, and also actually Dr. Shi, the second author, who who finished the training from Peru, Colombia, who's working with us in Loma Linda now. So what the authors did is they look at this, when we do scarf technique, does it work? Does it work, okay? That means immediate tube replacement and graft the gap and so forth and put that scarf tissue around the entrance and using the provisional to hold it, does it work? So in general, there's just some preliminary data here, all right? So the mean follow-up time is 8 years. And then the mean facial tissue change, okay, is actually 0.2 millimeters, very minimal. Now, bear in mind, this is not just all because of the scar tissue, graft, but also if providing the clinician put the implants at the right position and all the grafting done correctly, with the scarf, it is always going to be beneficial to maintain the tissue. Now, when the phenotypes on the thinner side, when we do the sashimi graft or the scarf tissue graft, will that thicken up the tissue based on this study here, up to 2.3 years of follow-up when they measure the tissue thickness. Actually, they often notice that a gain of tissue thickness of 1.4 millimeters. Now, however, there's one type of complication with scar tissue or any type of tissue grafting technique, when we do implant placement or even root coverage. I don't know how many of you done root coverage or immediate implant placement or tissue grafting in general and end up getting some sort of like a necrosis, tissue necrosis, okay? And in this study here, the authors find out 9% of necrosis, such as this patient right here that I've done, 4 years ago. You can see after the tissue graft, there's some necrosis on the middle picture there. But the interesting thing is based on this study, despite there's some necrosis, but none of them have any significant, or in fact, visually significant facial tissue recession. And that is in line with most of the publications by other people too. All right. So in other words, a lot of times when tissue graft procedures, when there's necrosis, we do not see very often marked gingival recession. Of course, once in a while we do see that, but majority of the time we do not. All right. So going back to our patient, you can see, remember the right central incisor is with the provisional. You can see the little yellow spot that has the screw retain, where I just put some composite to fill the space there. All right. So this is a 10 months follow-up, and with the definitive restoration. So, and then there's a definitive crown. So, and you can see, if you look carefully on the picture on the right-hand side, well, actually both photos, on high up towards the vestibule area, you can see a scar mark there. That's where I make that incision close to the vestibule. So that's why for this type of sensitive patients, I don't want to make a vertical releasing incision all the way to the pharyngeal margin, all right? But again, if you look at patients like that, with implant place, I believe is the right position, and also with the tissue graft, the scar tissue graft and contour grafting, you actually can get pretty decent results, all right? All right. Now, how about the soft tissue zone? How do we manage the soft tissue zone? Again, like I say, I just described to you one technique of scar tissue graft. How about dual zone? All right. So, and I'll talk about this. He's a physician. So, framing left central incisor, buccal bone intact. So how do we manage that? So you can see this is the situation here because of tooth failing, because of root resorption. And as I mentioned, this is a technique that was advocated by Steve Chu, a dear friend of mine, and the Atlanta team, and also Heini Sato, a very dear friend of mine who teaches in the Perio program in University of Maryland, and my dear friend Dennis Tarnell. So they published it in 2012. What they essentially say is this: after the implant placement, after grafting the gap, at that time they suggested to use xenograft to pack it all the way from the implant platform to the pharyngeal margin. All right, xenograft there. And subsequently, I believe Dennis kind of retracted that a little bit and say that it's best to use allograft in that area there. Okay, so this is just my patient here, what I did with the graft, and this is 16 months before, you can see the 16 months after healing, before I place the definitive restoration. So you can see the definitive restoration. So, we are also doing a study looking at the dual zone, the viability. So far, reasonably okay, not too much problem. The only problem that once in a while I face is I see some particles creating some information around the phalangeal margin area. That means particles, despite using allograft, I still get some small amount of information. What percentage do I get? Roughly between 12 to 14% of cases, I see some chronic information that, right around the soft tissue zone there. So point is this, regardless what you use, whether you use a tissue graft scalp technique or you use the dual zone, necrosis for tissue graft is around roughly 10%. The dual zone, the information at least we get from our data is roughly around 10 to 12% in that range too. All right. So, but when it works, it seems to work pretty good here. All right. So now let's look at patient number 3. What happens? Can we do immediate implant placement if the facial bone is compromised? All right. So as you can see, this patient actually is a specialist, a dental specialist, and came to me because of a failing left central incisor. So what I always do is to dictate whether to ascertain whether the facial bone is intact or not only by CBCT scan, like I told you, it may not be the most effective way. Then I always do bone sounding. All right. And of course, you anesthetize the patient first, and you can see there's a 12 millimeter where the gingival to the bone is. And what I also do is when I do the bone sounding, once I have the mid-facial bony defect, I like to take my periodontal probe and do bone sounding at the line angle, the mesial distal line angle of the tooth there. Then I also do the bone sounding on the adjacent teeth. And by doing so, I can dictate the shape of the defect. Why? Because, when you look at the patients here, this is the situation here. The facial bone is compromised. See, this is how I do the measurements. Now, what do I mean by the shape of the defect? Because we noticed that when the wider the shape in this 2007 article published in Journal of Maxillofacial Surgery, the authors noticed that when you do immediate implant placement with different type of bony defect shape, the V shape in which like an inverted V, or the U shape in which is a wider defect like an inverted U, then they have the YU-shaped defect. They describe that in which the buccal bone is compromised. Not only that, it also compromises the bone of the adjacent teeth. All right. So 3 types of defect. And if you still do immediate implant placement with bone and tissue graft, what is the result? And of course, provisionization. This is what the authors find out. Okay. In general, when the defect is Y, such as U shape or V shape, you have very minimal facial gingival recession despite immediate tooth replacement and bone and tissue graft. But when you have the YU-shaped defect, you increases the significant risk of facial tissue recession. So in general, what you learn is U-shape, V-shape, you can ascertain by using bone sounding and map it out. Under most circumstances in 2020 to today, we should be able to do immediate tooth replacement without much problems. Stay away from the YU shape. How about does the depth of the defect plays a role in recession? Absolutely. The deeper, absolutely not actually. This study tried to address that. What they did is they look at 25 maxillary anterior teeth with immediate tooth replacement. IIPP means immediate implant placement and placement of provisionization. And with a mean follow-up time 4 years, with a mean facial defect that was 7 millimeters up to 12 millimeters. And the authors find out that the depth of the defect, that means when there's a dehiscence or fenestration of the buccal bone, it should not deter you as a clinician to do immediate tooth replacement. So in summary, if the facial bone is compromised, can you do immediate implant placement? Yes, you can. All right, providing number 1 rule, the defect doesn't encompass that of the adjacent teeth. That means the interproximal teeth bone, adjacent teeth bone is intact. Number 2 is there should still be ample bone, more than 30% of the implant should be engaged into the recipient bone. And the palatal bone must be intact. Not only that, looking at incisively as the picture on the far right, you should be able to put an implant within that bony defect there. And if you follow this rule, of course, with grafting and tissue or hard tissue grafting, you should be able to get excellent aesthetic results despite compromised buccal bone. So going back to our dental specialist patient with the failing left central incisor, implant placement, just like what I described to you before. And in this situation, I put a combination of sino and allograft because I treated this patient, around 15 years ago. And then we put that piece of yummy sashimi between the gum and the underlying bone. You can see right there. And so what we call this is a contour tissue graft, all right? That means the tissue graft spans from the soft tissue bone all the way to the hard tissue zone. So the advantage of this is the tissue spans, all the way, from gingival margin to the apex, close to the apex at least. But the drawback is you need to, in a sense, despite tunneling technique, but you still need to separate the bone from the underlying, the periosteum to the bone, all right? So here I put a little crossing suture there. Now, does tissue graft work? Connect tissue graft when we work with implant. This article published in 2009, I believe one of the first article published on immediate implant placement and tissue graft. Okay, so you can see this patient is a hygienist, fractured canine, and the picture on the left is already implant placed with a provisional indent, and I created a tunnel, all right, and to tunnel the tissue graft through there, and you can see again, picture on the left is when patients show up with a fractured canine, and you can almost look at the phenotype, although I say visually is not the best way to identify phenotype, but you can see at 8 and 15 years, the tissue graft significantly thickened. And so based on this study, the authors find out that 20 implants with follow-up time of 2.2 years with the tissue graft and actually had a slight gain of facial tissue. So again, it emphasized the benefit of tissue graft. Bear in mind, of course, providing the surgeon put the implant in the right position and all the grafts are done correctly. Then one more articles on the benefit of potential benefit of tissue graft. This is published in 2014. What the authors look at is a prospective study comparing two groups of patients. After extraction, immediate implant placement, one group with tissue graft, the other group without tissue graft, all right? And what the authors find out is they look at this type of implants and, with or without tissue graft. And you'll notice that without the tissue graft, there's significantly greater facial tissue recession than with tissue graft. So again, in my experience, I think the tissue graft will be beneficial. So I would suggest when you do immediate implant placement, you either do tissue graft or do one of the other. All right, that's what I do in my practice. Then going back to our dental specialist here, place the implant in with the crossing suture and then definitive crown. Now, a lot of times I know as periodontists, you guys look at, the importance of surgery and so forth, but let's put it this way, the restorative part is equally important. Why? Because, in the literature, they describe, the emergence profile of the crown, the area between, between the free gingival margin to roughly 1 millimeter below or apical to free gingival margin, we call that critical zone, and the rest we call that subcritical zone, all right? So why? Because the subcritical and critical emergence profile and emergence angle is very important to the success, especially, in terms of the maintenance of the peri-implant gingival health. Why is that? Because recently you read the article, the literature on the Journal of Clinical Periodontology, I think 2019, 2020, and also 21. There's a series of articles published in, from the University of Washington Perio program and also some Korean groups and the Japan group. They look at the prevalence of emergence profile, or does the emergent profile, emergence angle play any role in subsequent periimplantitis? Okay, so this is their general rule. They find out that if the emergence angle, emergence angle of the crown is 30 degrees or greater, that means very exaggerated, or if the emergent profile, well, emergent profile can be defined as straight, convex, or concave. All right, concave is like concave, convex, or straight, right? So if you have an implant that have greater than 30-degree emergence angle, and the emergent profile is more so on the convex side, the chance of the prevalence of peri-implantitis is very high, more than like 35%. I mean, some huge number there. So the authors here decide to do their own study to look at the emergence profile. Does emergence profile or emergence angle play a role on peri-implantitis? And this study, with Dr. Suni, Dr. Chung is our faculty and graduate student, and Alberto Montes, my dear friend, and Alex Lin is a wonderful, is a program director, graduate director at UCSF. So on this study, they look at maxillary anterior teeth, and all those implants are platform switching implants. So let's see what the data shows. Okay, to be published material, so 61 maxillary anterior implants so far. Follow-up year time is 4.6 year. And then now, what is interesting is almost 50% of all those maxillary anterior trunks have greater than 30-degree facial emergence angle. That makes sense because most surgeons are trained to put an implant more palatally. Therefore, if you look at the column, the second column I highlighted, 28.9, that's a mean facial emergence angle, all right? And then they're fastly approaching 30-degree. So most maxillary anterior teeth, the facial emergence angle is approaching 30-degree already, all right? Now, but the good thing is only 3 of those scenarios have a convex emergence profile, all right? And so if you look at how often in this study do they have peri-implantitis, is less than 10, is around 10%, all right? And interesting thing is majority of them, the emergence angle is actually less than 30-degree, but they have convexity on the emergence profile. So based on this study, the authors kind of, so far find out that I think the emergence profile play a much more powerful role than the emergence angle. So key point to remember is try to have the restorative dentist to stay away from convex emergence profile, all right? And that can only happen if the surgeon places the implant very, very palatal and the soft tissue is not thick. So the restorative dentist have no choice but to make the facial emergence profile very convex to compensate for that soft tissue and the implant position, all right? So anyways, going back to our dental specialist here with the failing tooth, definitive restoration, and then, so this is a follow-up over 16 years. And again, remember, no facial bone. And if you look at it, the results are pretty good there, right? I mean, pretty good. All right. So now, last but not least, we go to our final patient here, okay? So this patient's a oral surgeon, okay, failing left central incisors. But I noticed that there's someone already placed an implant on the left central incisors. So you can see this is the interproximal bone here. And this is the distance between implant and failing tooth. If we put an implant in there, what do you think will happen to that sharp piece of bone? It will disappear, all right? The thin, sharp lateral bone disappear. And what do you think will happen to papillae? It will disappear, something like that too. So what will happen? What do you think will happen if we decide to, rather than extracting the whole tooth, leave a fragment of the tooth on the mesial aspect of that implant there? Will that hold will that maintain that piece of bone? Well, this is what happened here. Okay, so this was actually published in 2013 model. So how do we manage that there? Okay. So the way we manage is the hard tissue zone. All right. So that means doing the root shield here, right here. All right. So for our patient here, I extracted the tooth, but leave a fragment. You can see the picture, third picture on the left here. I left a fragment of the root on the mesial to maintain the papillae. So during the healing, and the picture on the far right is when I changed the provisionals. And so this is a 7-year follow-up on this patient here. You can see, and in fact, you can see before and after picture. Now, does root shield work? I mean, somewhat controversial. I would say this is this article will be submitted next year, all right, into this journal of maxillofacial implants. What the authors did is looking at comparing a randomized controlled clinical trial of two groups of patients needing maxillary immediate tooth replacement, and one group with root shield, the other group with the dual zone grafting technique. It is a randomized controlled clinical trial. So with also my dear friend Marcus Herzler and Otto Schur, and Otto was a wonderful dear friend who also has spent some time with me in Loma Linda. And so, you can see the dual zone versus the socket shield, and then none of them have periodontal disease and so forth. And then they look at volumetric changes, all right? So right now, so far, all right, maintain the root shield helps to maintain the facial contact a little bit better at 1 year, all right, compared to the dual zone. But that doesn't mean that by doing the dual zone, you have a lot of problems too, okay? Then lastly, I'm going to show you this article that was set for publication. What the authors did is they look at when you do root shield between two implants, does that maintain the papillae better, all right? So this is what the authors find out. With, they look at 26 inter-implant papillae with root shield. Mean follow-up time is 41 months. The papillae loss is only 0.4 millimeters. That means half a millimeter papillae loss with the root shield. Compared to on an average, you can lose 1.5 to 2.5 millimeters without root shield, all right? And now, is there complication? Yes, the complication is shield exposure, 25%. That's very significant. So if you're going to do that type of procedure, make sure your restorative dentist really under contour the emergence profile to leave at least 1 millimeter to 2 millimeters of distance between the shield, exposed shield, and the soft tissue for the development of the soft tissue, all right? So anyways, to summarize, what do we know about immediate tooth replacement in 2022? I mean, in my humble opinion, they work. I've been working on this for 25 years. And I mean, do I have my share of problems too? Of course I have, especially early on. But nowadays, things became a little bit more predictable. And then with the contour grafting, with the scar tissue grafting, and also, even to the extent of root shield, which is a little bit adventurous, but even with root shield, I mean, under my hands, I mean, this is year number 13. I have 13 years of experience on it, and it's not that we have a lot of complications too. So there's always a learning curve. What advice do I have to share with you? Well, I believe in 2022, immediate tooth replacement is absolutely a treatment option. All right. The question is whether the clinician have the knowledge or skill enough to execute it. And by following what we know right now, the different methodology and thinking process, we definitely can achieve excellent results with it. So once again, I want to thank the AAP for putting this together, because I know it's a lot of work, and then they did this solely for the benefit of the residents. So you graduate students are very, very lucky to have this type of support. And I want to thank all of you for spending time with me and listen to this. Then we'll get back together with all of you to discuss about this. And remember, the best way to learn is to ask questions. So, don't be passive, don't be shy, ask lots of questions, because this is the best opportunity for you to learn. So I'll be seeing you, I believe, in 2 weeks, and we will have some fun again in that Q&A session. Thank you again for attending.